Al giorno d'oggi, per la terapia della leucemia linfatica cronica è possibile impiegare due approcci differenti. Uno basato su una terapia continuativa con farmaci della classe degli inibitori di BTK, l'altro che invece ha durata fissa, basato su combinazioni dell'inibitore della proteina anti-apoptotica BCL2 venetoclax con altri farmaci. Noi facciamo il punto su queste due strategie con un grande esperto di questa patologia, il dottor Othman Al-Sawaf dell'Ospedale Universitario di Colonia. Okay. Dr. Al-Sawaf, first of all, what can be used as a continuous therapy and as a fixed duration therapy for chronic lymphocytic leukemia in Europe at the moment?
So in Europe, we have basically the two paradigms available in most parts, or generally they are approved by the EMA in all EMA countries. So we have on the one hand the continuous BTK inhibitor class, which is acalabrutinib, zanubrutinib, and ibrutinib. So we have the first generation inhibitors and the next generation inhibitors approved for first-line therapy of CLL as well as for relapsed refractory CLL. And then on the other hand, we have an EMA approval for the combination of the BCL2 inhibitor venetoclax with either the CD20 antibody obinutuzumab or in combination with the BTK inhibitor ibrutinib, again in the first-line setting.
Recently, at the last Italian Society of Hematology Annual Congress, you gave an interesting presentation about a comparison between these two different strategies. That remains a highly debated issue. First, based on the available evidence, which ones should be the preferred option in terms of efficacy? For instance, response to treatment or a rate of undetectable minimal residual disease?
So in terms of the depth of the remissions, clearly we can see across all sorts of studies and data sets that combination therapies given over a limited duration of time produce deeper remissions than single-agent continuous therapy. So both the rates of, for instance, complete remissions, as well as the rates of undetectable minimal residual disease at various thresholds from 10 to the -4 down to 10 to the -6, all these rates are substantially higher with combination therapies compared to single-agent BTK inhibitors. When it comes to survival, the data seem to be very comparable as far as we can tell across different studies. So the efficacy in general seems to be very similar with continuous and with limited duration strategies in the overall patient population, but there are possibly distinct subgroups of patients with different genomic backgrounds that might benefit more from one approach compared to the other, but this is so far only based on cross-trial comparisons because prospective randomized studies comparing these very two principles are still ongoing, and we still need a few years to see these results.
What about the toxicity, as it is, of course, a very important aspect as well? Which approach between continuous or fixed duration therapy is preferable from this point of view?
In terms of toxicity, there are certain overlaps in terms of the quality and quantity of toxicity. So we know that both with single-agent treatment as well as with combination treatment, hematological toxicities can be quite common in a sense of neutropenia, thrombocytopenia, or anemia. But generally, it seems that when, of course, we have a combination treatment where we combine 2 or 3 agents together, the short-term toxicity with combination therapy seems to be higher than it is with single-agent treatment. On the other hand, though, we know that over time there is, of course, an increased risk of toxicities when we have to keep patients on an agent for multiple years, whereas we know for sure that with limited duration treatments, the risk of toxicity is fairly limited to the 1 or 1.5 year of therapy that patients are during which the patients are taking any treatment. So it's really a balancing clinically with the patient in terms of what can be accepted as a short-term toxicity and long-term toxicity. And ultimately also we need to take into account the agent-specific toxicity. So we know, for instance, that BTK inhibitors are associated with a certain cardiovascular toxicity signature that is not present when we use BCL2 inhibitors, for instance, in combination with CD20 antibodies.
And which kind of treatment you can use at relapse with the two different approaches?
So in the relapse refractory setting, we pretty much have, again, the same two paradigms. So on the one hand, we have the availability of single-agent continuous BTK inhibitors. And on the other hand, we have one option of limited duration treatment, which is venetoclax in combination with rituximab, which is a 2-year regimen. So it's not as short as in the first-line setting based on the data from the Murano study. But here again, the same principles and aspects are relevant as in the first-line setting. So toxicity profile, weighing in toxicity risks with a shorter and a longer treatment, patient preference, and all of these parameters have the same role as in the first-line setting. So these are the two possible strategies. And in addition, we have, in the context of limited duration treatments, especially when it is used in the first line, we also have the possibility to retreat patients again with limited duration treatments in the relapsed refractory setting, which is an option that's only available when we use really limited duration strategies. So retreatment certainly as an option to re-expose patients to the same agents as in the first line setting if they had a prior good response.
Last but not least, about the cost issue. Which strategies, continuous or fixed duration therapy, is most convenient for the healthcare systems?
So of course, it stands to reason that when you use a shorter therapy, you have less health expenditures, less health care costs compared to a treatment that you give for, let's say, 5 or 6 years. So there are some analyses that have been conducted in the past that suggest that these kinds of limited duration treatments also have a favorable health economic impact. On the other hand, of course, we are using multiple expensive agents when we use combination treatment. So the treatment benefits and the efficacy advantages that we gain need to be really substantial to justify combining multiple agents in the first line or in the relapse setting, rather than using a single agent for multiple years. But so far, it seems that generally a limited duration strategy seems to have a favorable health economic impact compared to a continuous indefinite treatment.